Analgesics. Analgesics are medications that relieve pain without causing the loss of consciousness. People call them painkillers. We have opioids. We have NSAIDs. We also have non-opioids, non-NSAIDs. Pain is whatever the patient says it is. It exists whenever they say it exists. You have to believe them. It's an unpleasant sensory or emotional experience associated with actual or potential tissue damage. It is personal and it's an individual experience. There are many cultural implications for pain. Some cultures, you express pain. You let it all out. You're very verbal. Other cultures, you don't. You hold it in. You be stoic. You don't let it. You put up that brave front. For some people, pain is punishment from God. They've been bad. They deserve this pain. Be aware there's lots of traditional remedies out there for pain. And I'm going to refer you to the box on page 137 that talks about some of the cultural implications and pain. Okay, a pain threshold. That's the level of stimulus that's needed to produce the perception of pain. You know, I stick you with a pin, it may not hardly hurt at all. I stick the next person with a pin and it may be excruciating. So it is what it is for that individual. It's very personalized. We can decrease that threshold with anger, anxiety, depression, discomfort, fear, isolation, chronic pain, sleeplessness, tiredness, all of those things. Think about it. When you're tired, don't you hurt a lot more? Doesn't it take a lot less to make you hurt when you're tired or when you're anxious? Conversely, the pain threshold can be increased by using diversion or distraction. You know, you got this terrible headache and you get wrapped up in doing something else and you forget you got the headache. Empathy, rest, sympathy, medications, all of those will increase the threshold. That means it takes a lot more stimulus, a lot more bad things happening before the person feels the pain or perceives that they're having pain. Pain tolerance. That's the amount of pain a person can endure without it interfering with normal function. And it varies from person to person. Again, it's very subjective. It's not a physiologic function. It's very subjective. And it's the point beyond which pain becomes unbearable. We classify pain several ways. I'm going to refer you to table 10.2. Does a nice job talking about the different types of pain. Acute pain, it's sudden, it's got a sudden onset, and it usually subsides once it's treated. It's a one-shot deal. Versus chronic pain, which it's there all the time or it recurs. It lasts 6 weeks or longer, or it keeps recurring longer than 6 weeks. And it's often very difficult to treat. As we continue with this conversation, I want you to think about chronic pain. What do you want this person to act like? We in the medical profession tend to discount chronic pain because people with chronic pain learn how to deal with it. Doesn't mean they're not hurting. It means they know they just got to work through it and keep going. And when they come into the hospital, they've learned that people don't believe them. They don't believe they're having pain unless they act up and cry and whine and all that other kind of stuff. Is that really what we want to be encouraging people to do? No, I believe we need to encourage people to tell me, you got pain? I'll believe you, and I'm going to give you medication for it. Yes, some people do seek drugs. They come here to try and find drugs and have a high, but most people who come into the hospital and come into the medical system are not doing that. And what would you rather do? treat somebody who really doesn't have pain? All right, that's part of their, they've got a drug problem. Or would you rather withhold medication from somebody who really has pain because somehow you don't believe they're acting bad enough to get that pain medication? If we have all these different classifications of pain, again, I'm going to send you to your book, say please know the difference between each of these types of pain. Alright, now it's time for some pain theory. As you look at this diagram, you can see the left-hand side is talking about the peripheral system. That's everything except for the central nervous system. That's all your body, your toes, your fingers, your organs, everything except for the brain, spinal cord. The right-hand side of the body, the right-hand side of the slide is looking at what's happening in the brain. So it's in the body we have some kind of tissue damage going on. And that sends a message along a nerve pathway to the brain, and it's in the brain that we perceive pain. We can attack the pain and treat it at several different levels. Okay, we can look at the tissue level. At the tissue level, there's a release of bradykinins, histamines, potassium, prostaglandins, and serotonin. And that all adds into going through the nerve pathway and perceiving pain in the brain. Those things are part of the healing process, but they also give you pain. The non-opioid drugs attack pain in the periphery at this level, at the tissue damage level where all these things are being released. Well, we can attack pain at the brain level, and that's your opioids, your narcotics. When we give people narcotics, we are treating the brain. And the third level is to look at the gate. The gate control theory says, there's this gate we can use that people have that blocks the message that's traveling along the nerve pathway. Some of those things are an alternative stimulus. Very common one, massage. If you give somebody massage, it overloads that nerve pathway so that you don't get as much of the pain transmission getting through into the brain. And the other thing that helps to break that or close the gate so the pain message can't get through is endorphins and enkephalins, and they are all produced by the body. The person who's got some kind of tissue damage produces those themselves and closes the gate so that the pain perception can't get through. The other kind of alternative stimulus that I didn't mention, I'm sorry, is a TENS unit. It's an electrical unit that's attached with little patches to the person's body wherever the pain is, the tissue damage is, and it's attached to this little battery pack, and a little electrical stimulus comes through. And that actually works to close the gate. It works on that nerve pathway to close the gate so that, no, the tissue damage hasn't gone away, but as it's traveling along the nerve pathway, the gate is closed so the message can't get through to the brain. So we have 3 different levels. We can be attacking pain and treating pain. Please remember, it's not just pills. We do a lot more. Nurses do a lot more than just hand out pills and give shots. We can be doing many things to treat pain. Think about the things we talked about in increasing and decreasing the threshold for pain. We can be using massage. We can be calming people down. We can be giving them sympathy. There's just many things. We can be using distraction. That's one of the greatest ones around. It doesn't last for long, but it'll last in a short period, in the short term, to help deal with pain.